Good afternoon, and I'm Jean Fajadet, and I'm really pleased to have with me Thomas Cuisset, and we will talk about a main issue concerning the revascularization in patients with multivessel disease. So the goal of this sponsor session by Terumo is to discuss first the concept of complete or incomplete revascularization, and you will see during the talk of Thomas the concept of functional complete revascularization. And then we will move to the cath lab in the Poznan with Maciej Lesiak for a very interesting case. And the goal of this case will be to discuss the role of and the revascular PCI in a patient with multivessel disease, and in particular with distal calcified bifurcation, left main bifurcation lesion. I invite you, all of you, to send questions to the chat, and we are helped by Sylwia from Poznan, who will be our chat master. Do not hesitate to send us a lot of questions, and we will try during this hour to answer to questions and relay all your comments. So, I think we can start by Thomas, the concept of complete versus incomplete revascularization.
Yeah. Dear colleague, during the next 5 minutes, we will then discuss together the value of complete or incomplete revascularization and try to see how we can balance the risk. We know that the benefit of complete revascularization has been based mainly on angiographic-based studies, which concluded that complete is better than incomplete for patient outcome, including mortality. But of course, this kind of dogma of complete revascularization has some pros and cons. And for the pro, of course, with complete revascularization, we will have less ischemia, less symptom, and therefore better prognosis for the patient. But with complete revascularization, we will have more complex procedure and potentially higher rate of complication, and we will put more stent with higher risk of stent thrombosis and in-stent restenosis, which can impair the prognosis of the patient. But first, we have to think about what means complete revascularization. What is complete? It means revascularization of all stenosis of more than 50, 70, or 90% on the angio, or stenosis with impact on physiology or on prognosis. So following that, the main question is how to assess the completeness of revascularization. Should it be angiography guided or physiology guided? Because we know that when we look at the difference between angio and FFR for the definition of multivessel disease patient, here you have patient defined as three-vessel disease with the angio. And when we do FFR, we can see that only 14% of the patient will be still three-vessel disease. It means that identification of multivessel disease just by the angiography is probably not ideal in many patients. So poor identification of multivessel disease means that angiography alone is probably not reliable to guide complete revascularizations. And of course, we have to see the value of physiology and imaging in some cases. So just one word on the different clinical presentation for the completeness of revascularization. In ACS, of course, revascularization of the culprit lesion is a life-saving procedure, and the non-culprit lesion could be considered as stable ones. While in chronic coronary syndrome patients, all lesions could be considered as stable ones. So in ACS, we have the support to say that we have to do in-hospital complete revascularization. It can be PCI or cabbage in some selected cases, and it should be PCI of critical lesion or lesion with FFR below 0.8. So just one case to illustrate this. In this patient, 70 years old, anterior MI, occluded LAD, and 60% on the right. If we do complete visual revascularization, then we will treat the LAD and the right. But if we guide our decision with the physiology, we see that the right is only 0.86. And accordingly, the FFR-guided revascularization will be a single vessel PCI with primary PCI of the LAD. In the chronic coronary syndrome, for the complete revascularization, a key point is the timing, and often we can use stage strategy, which is often safer to assess lesion, but also for procedure and, for example, the contrast load and the X-ray. And to do complete revascularization, we can do PCI or cabbage in patients with highly complex anatomy, and we should treat PCI of critical lesion or lesion with FFR below 0.8 on major vessel. So of course, let's say that the complete revascularization is the rule, but in some case, like this one, we have a male of 82 years old with chest pain, and he had prior LAA closure for intracranial bleeding. And as you can see, he has a tight stenosis on the LAD and CTO of the right. And of course, the complete, what we can say again, visual revascularization will be PCI of the LAD and CTO of the right. But in this case, because we have patients with high bleeding risk and we have quite complex lesion on the right, the strategy was to do PCI of the culprit LAD only and conservative approach first for the CTO of the right. And at 6 months follow-up, the patient has no more pain and therefore was considered for conservative approach. So just these two cases to summarize the main take-home for the complete revascularization concept. First, we should consider functional complete revascularization with evidence of ischemia or physiology-driven PCI. We should treat lesion with prognosis value and not treat all the stenosis even on a small distal branch. And always we have to balance the benefit and harm of multivessel PCI, especially in some frail patients like the high bleeding risk patients. So we can agree that complete revascularization is the rule, but factors could favor a more conservative approach, which are patient-related, like HBA or comorbidities, or lesion-related in terms of complexity, and CTO is a good example. And at the end, as always, there is no one absolute rule, and we have to do and use a tailored approach according to patient and anatomy. Thank you very much.
Yeah, and if we can just maybe add one word on the concept of complete revascularization, we would like to mention what you can see on this slide. It's recent data from the eUltiMaster registry showing again that complete revascularization provides to the patient better clinical outcome than in patients without complete revascularization.
No, thank you, Thomas, for this introduction, short lecture. But I think this will be really useful and interesting for all of you following us. And I'm sure that we will have a lot of questions coming from the chat. So what we have really understood is this concept of functional complete revascularization. And now I think it's time to move to the Poznan, to the cath lab in Poznan, to join Maciej and Lesiak.
So our patient is a 64-year-old male with class 2 angina, active normal cognitive function, with BMI of 24, and his risk factors is hypertension, diabetes class 2, dyslipidemia, peripheral artery disease, and ex-smoker, a heavy smoker in the past. His ECG is quite normal, sinus rhythm, ejection fraction on TE also normal, and the patient is on aspirin, bisoprolol, ramipril, high-dose rosuvastatin, and due to diabetes, he's got type 2 diabetes mellitus. He is on metformin 1000 milligrams twice a day. And that's the baseline angiography. So we see a severe tandem lesion in the mid portion of the right coronary artery and significant stenosis at the bifurcation of left main, perhaps involving a proximal part of the LAD. What you also can appreciate, there is a trifurcation, but we do not see, at least at this baseline images, any involvement of the ostia of the ramus or ostial circ. His syntax score is 25, and syntax score 2 was also calculated, and we see that there is an equipoise. So the recommendation is either CABG or PCI, and we decided for PCI. And we also calculated syntax score 2020, and you see after 10 years, both mortality and 5 years MACE is exactly the same, so there is no difference for this patient. So I think PCI here is quite justified. Thank you. The point is to use a 7 French catheter, which gives you a better backup. So this is EBU 3.5 with a good force, backup force. And 7 French, you can try and manipulate with multiple techniques. And of course, we use the slender sheath, which is outer diameter sheath with like 6 French, but the inner diameter allows a guiding catheter, 7 French guiding catheter. So you can use without not a big bore, you can advance easily any 7 French catheter you like. My default catheter is EBU 3.5 from the radial, and this is what you actually see. The second issue is the right coronary artery. I think the stenosis is not very, it's not subtotal, so there's still good flow in the right. So I prefer to start with left main first, fix the lesion in the left main, and then if everything is okay, the patient feels okay, and we do not use too much contrast or radiation, then we will move to the right course. To the caudal view, Arek, jakbyś dał do nóg. I think that provisional strategy is the good option to start with. Keep in mind that this provisional is more like philosophy and not the technique, so you can always switch to another strategy. So if after pre-dilatation and stenting you have issues with any of the vessel, you can change your strategy and finalize with 2 stenting, double stenting. You have a lot of options. You can do a tap, you can do culotte. So I think we generally, in this situation, I generally start with provisional, and if needed, of course, we will stent also the branches.
Okay, so you have seen, all of you, the case presentation, the clinical data and the angiography features of this patient with really free vessel disease. These 2 lesions of the mid-right coronary artery and the lesion of the distal left main, which is quite heavy calcified and including all the proximal LAD. So I think that we can, if you agree, Thomas, ask to Maciej. So hello, how are you? And we have a lot of questions coming from the chat, and there is one question. It's concerning the strategy and what you first vessel to treat. You say that you will start from the left main. We have some comment on the chat. Why not to start from the right coronary artery? Can we give some new arguments on that?
Thank you. Hello, Jean. Hello, Thomas. As I explained during the case, so the lesion in the left main was more complex, and the extent of the ischemia was higher, was greater. That's why I decided to start with left main. And then, as you probably noticed, I said that if everything is okay, then I move to the right coronary artery and try to fix all lesions in one setting. So this is what I do in most of my cases. First, treat more difficult lesion, and then even if I can, I do everything in one setting. If not, I stage the procedure for the next couple of days or weeks later.
Oh, thank you. Very clear, Maciej. Thomas, any question coming from the chat?
Yeah, we have also a nice question is to say that now that we decided to do left main PCI for this patient is to know whether the angio is enough or not. And personally, I think that we have critical lesions, so probably I will not use physiology. But for the left main PCI, I will definitely use imaging because, as you said, it's calcified and we need to define what's going on. And also, we want to optimize the PCI results. So I will definitely use intracoronary imaging for this left
intracoronary imaging. Yeah. You agree, Maciej?
Yeah, of course. And you will see in the further steps how important actually imaging was in this particular case.
Okay, so what we can do now is to come back to you in the cath lab.
So we start with extra support wire to the LAD. And 2 regular workhorse wires to the circ and intermediate. Can you show it? Okay, so it must be calcified because if you have this kind of friction, then you know that go to cranial. Okay, now we can go with the loop. And now we wire, in the meanwhile, we wire the other 2 branches. Nabrać troszkę powietrza, proszę.
To było
Oddychamy. Możemy ewentualnie spróbować jeszcze raz po predilatacji, nie? Okay. No jestem tylko. Okej. Dobra. Wiesz, jak już powiedziałem predilatacja, przestraszył się i wszedł. Dobra, pyknij lekko. Okej, dobra. Trochę niżej.
Jeszcze niżej.
Tak. So we will start pre-dilatation with 3-hole balloon, and we will start from the LAD because I think that the stent should reach this LAD. So this is 15 millimeter long 3-hole NC balloon, AccuForce balloon. It gets there very easily. Open also with what pressure?
So far it's 8.
8, okay. Deflate. Okay, here.
It's 8 again.
So we are closer now to, okay, deflate, nagraj, Arek. So now we are closer to the left main, so we see there is more calcium and Sylwia, ty jesteś teraz tam na tej wysokości? And it's really, this part is really calcified, both in the both in the proximal part of the LAD and distal part of the left main.
Mogę powiedzieć coś ewentualnie?
Okay. Nagraj. So what was the pressure?
It was 10.
Okay, so let's go to 18 now. Let's check whether the balloon opens. Yeah. Okay. Thank. Dobra. So you see there's poprosimy jeszcze 1 3-0. So now we will try to go to higher pressure with 3-hole balloon to check. Yeah. Okay, so now the balloon opens. So I think there is a chance of for a good opening of a stent as well. Okay, deflate. So in the meanwhile, we have some analysis of the OCT. So Sylwia, please tell us about the reference of the vessel diameters and something about the plaque composition.
The minimal diameter is about 3.2 and maximal diameter is about 3.4. Minimal lumen area is about 8.6 millimeters. And when we go to the proximal part of the vessel, we can see here fibroelastic plaque. And going to the proximal part, also we can see fibroelastic plaques, and there you can see calcification.
But this is a kind of deep calcium?
There is a kind of deep calcium with thick cap of the plaque.
Fibrotic cap, yeah.
Yes, and there you can see this is a massive calcium, very huge. There we can see a diagonal branch. Here is a diagonal branch.
So calcium is located mostly at the one side of the at the 12 o'clock. Yeah?
Yes, generally yes, in this part of the vessel, yes. However, there you can see cap of the plaque. It's thin rather. It's less than 65 micro-m, so it's a rather thick fa. And when we are going to the proximal part, the massive calcium is still here. It's and there you can see also is calcium, and
yes,
there
so
you can see a massive calcification of the artery. It's about 190 degrees of the vessel. And there you can see also superficial and deep calcification of the vessel.
Mm-hmm.
There you can see,
so given the large lumen relatively to this calcium, I think it would be very difficult to get it to break the calcium with the rotational atherectomy, because most of it is a deep calcium, and the lumen is like 2 millimeters. Yeah?
There you can see calcification around the vessel. In the proximal part of the
this is
LAD.
Still LAD.
Yes, this is still LAD. This is proximal part of the LAD. We are going to the left main.
So show us the bifurcation. Yeah.
Yes, of course.
It's very nice picture. Yeah? Very nice.
And
yeah.
there you can see circumflex artery. This is a bifurcation.
So it's true that there is no much plaque at the ostium. So this is what I mentioned, that with OCT you can visualize correctly the ostium of the branch, which is in most of cases impossible with IVUS.
Mm-hmm. Yes, that's right. And there is a left main. And the minimal lumen, of course, this is also before. Oh, sorry. Okay.
So perhaps the first one was. I think the first one was this this intermediate. Yeah,
that's right.
And then the second one is. But what I also see is that actually there is a one branch, one takeoff, and it splits into two. So they have the both branches. They have a common takeoff. Yeah.
It is good visible in the longitudinal view. Yeah, we have two separate arteries, and so now we can circumflex artery ostium, and this is a.
But the left main in the distal part is free, mostly free of disease.
That's right. And this is a distal part of the left main. This is a rather lipid-rich plaque.
In the
Of
left
course,
main.
there is a calcification also, but rather, I suppose it's rather soft plaque. And the minimal lumen area is 1 second. It's a minimal lumen area is 4.3 millimeters.
Okay. And could you tell us what length of the stent should we use going from, I don't want to, we do not need necessarily go from the ostium of the left main. Can you tell us something about the rest of the left main? Is the plaque
Yes.
burden very large or it's minimal disease?
Unfortunately, there is a lot of calcium here. As you can see, there is around the artery. This is calcium.
But
as you can
what's
see,
what's the lumen here?
The lumen, the diameter.
Yeah, the area.
Area is about 9.2.
And going more proximal?
And we are going proximal, and there is still
it becomes
a lot
bigger
of
and bigger.
calcification. Yeah, the diameter, the area, it's okay. And we are going, and it looks better. Yes, there we can see intima without. There is of course calcification. However, we can see the normal wall of the artery here.
So in fact, we do not need to go to the ostium, Maciej. What do you think?
Yeah, I think that if I don't know, if I do not do imaging, I try to cover the whole thing, the whole left main, unless I see that the proximal part of the left main is a trumpet-like shape. Then of course you will never be able to get the stent apposition. But here I think we can leave the ostium uncovered. And what's the advantage to the patient? Because if we cover the ostium and we will do some further manipulation, rewiring, kissing, etc., we can damage the edge of the stent. And we know from Excel study that it translates into clinical outcomes. Yeah, so it was one of the independent predictors of MACE in a 3-year observation. So if I don't need to, I skip the ostium.
So well, about the length of the stents, I think we should start in this landing zone. The vessel, it looks quite normal here. And so about the proximal part, for example, here to pot, usually do perform.
So like 32, about, 33, 34, something like that, you know?
That's right.
So it was really wonderful, great images from the OFDI technique, and thank you, Maciej, and your team to give us this opportunity to see really the high quality that we can get from this OFDI. And from this OFDI, we saw that it's a heavy calcified lesion. And second, we saw very nicely, you show that the opening of the ostium of the left circumflex artery, which is really important in the decision, in the strategy to treat this left main. So concerning this amount of calcium, the question will be why not to perform plaque preparation using an atherectomy device, or, because it's quite deep, lithotripsy in this case. Maciej.
Yeah, of course, that's a very good point. I think that lithotripsy would be more suitable here than rotation atherectomy, because then we need a really large bore, which I don't like. In most of cases, we use just a rotation atherectomy to break the calcified ring, and that's it. Here we could appreciate that the calcium is located in multiple points very deeply. So of course, EVL would be a good option to this patient, and I'm really sure it will help to expand the stent.
Yeah, thank you. And particularly, of course, in case of rotational atherectomy, maybe we have to treat the right coronary artery first. Thomas. Any question to Maciej?
No, that was exactly the comment that you just mentioned, Jean, about the fact that if you have to use atherectomy and you might experience a slow flow in the left main, it's probably better to change your plan and to decide to treat first the right. So it was exactly the point you've just mentioned here.
Other question coming from the chat?
The other question was to know how to decide in left main PCI to treat up to the ostium or not. And it's indeed a very difficult question. We have to consider the length of the left main, the size of the left main, and the discrepancy between the left main and the LAD. But also the imaging findings from the OFDI are really key. Because we've seen that in this case, we had calcification, we had some plaque. So decision is really difficult. But I think that personally, I will probably, Jean, will have stent up to the ostium, but I think there is no absolute truth, and that's just the difficult decision.
So what we can do is to move to the cath lab now and see how Maciej performed the case.
So now we try to pre-dilate with 3.5 balloon and check what's the expansion of the balloon. Okay, a little bit further. Okay, go ahead, Marek. So let's go no more than 10.
It's 10.
Okay, go 14. I think that we can stent the left main with 3.5 Altimaster stent, optimize the proximal part, take care of branches if needed, and then decide, do we stick to the simple provisional procedure or do we need to do something more? So the stent entered the bifurcation with no big issue. So now let's check the distal reference. Go to the cranial view. So where we are, okay, Poznan. I think we can go slightly more distal. Poznan. Like that. There is some dissection there. Go to caudal again. So now we need at least 8 millimeters for, yeah, I think it's okay. 8 millimeters for to do the pot. Okay, so let's go up to 10, 12. We jail both wires in both vessels.
It's 10.
10 atmospheres, nicely open, no, nicely opening. Okay, leave it like that. Nagraj, Arek. Stop. All right. And then please give me 3-all NC balloon, 3-all NC balloon, 3-all of, yeah. So we do the distal optimization. So we post-dilate distally with 3-all. And then I need a short 4.5 accuforce to optimize the proximal part of the stent. So this is 3-all over 15. So we go now high pressure, like 20. This is accuforce, so RBP is 22. Okay, go down. We can go also high pressure in the bifurcation lesion, region. Okay, go ahead. You cannot do this in a cranial view. So yeah, so now we see we have to go a little bit further. Okay, check, test. Yeah, I think like that.
I think that it's okay.
Aspirate? Yes, it's aspirated. Let's check again. Okay, I think we are in the correct position. So now we can go up to 18. So another important issue is that if you do the pot, be sure that you also post-dilated the proximal part. So we are a little bit more too proximally now, yeah?
Yeah.
So we have to go a little bit more distally. Like that, okay. Go ahead. Yeah.
Okay.
I think we were the first time.
So.
Let's check. Yeah, so there is a pinch in the circ.
So there was some question coming from the chat. The first one is concerning the type of wires. You have the jailed wires, we have your 3 wires in place, 2 jailed wire. And what type of wire do you use? Can you use a standard wire or hydrophilic wire?
Yes, you can choose both wires, but what I do when I do bifurcation stenting, especially when I use more than 2 wires, I never use hydrophilic up front, because if I don't have to, because it's more difficult. It's very safe to jail the regular wire. It's also safe to jail current hydrophilic wire. We have some data from scan microscope that you will not peel off the much of the wire, so it's safe. But as I mentioned, it's more difficult to handle the hydrophilic wires, especially when they are more than 2. So I always use just a workhorse wire.
Okay, Maciej. Thomas, question from the chat.
Yes, Maciej, we have another question for you. It's saying that, okay, you put a stent in the LAD and the pot, you have a very nice result in the left main and the LAD. And on the circ, you have good flow from one side, but it looks a little bit tight. So people are asking just to mention the 3 different options. One is just to stop. One is the pot side pot, and the next one is the kissing balloon. And just for you to explain which one will you select and why in this specific case?
Yeah, of course. So my strategy, default strategy, is that if the circ is not the dominant vessel, and I have angiographically good result, and what's more, I use imaging and can check it, I leave it like it is. So I do not fight much for the ostium of the circ. Unless, of course, there is a flow compromise, or there is a dissection, or there is some significant, very severe lesion. Here, what we have to do and will do is to do imaging. Yeah? As I mentioned, with OFDI, you can, upon the picture from the main vessel pullback, you can estimate, you can assess what's going on with the ostium of the side branch. So here we can check, and of course we may react accordingly. The third thing is you can use FFA wire, but there is no big data and enhancing data, encouraging data to use it. We know the study DK Crash 6 that show that it's rather useless. So still, we don't know whether using physiology in this particular situation.
Okay. So the practical message will be just to check on the imaging and then decide whether we need to touch or not the side branch, especially when the side branch is the circ. Thank you, Maciej.
Exactly. And this will be very nice demonstration how angiography may mislead you according about the status of the ostia of the side branches.
Okay, very clear. And I think now we can move to the cath lab to see the next step of the case.
So let's check with OCT. Let's check what OCT will tell us. Okay, yeah, and now we approach, is this some calcified nodule that pushes the struts here, or
yes.
what's this is? Because this is not the...
Okay, so there is this is a calcification which protruding into the vessel lumen. Now we are going proximally.
Yeah.
This is the same situation. This is also the malposition. It's
so
very
I think this is this big mass of calcium we saw.
That's right. So the expansion of the stent in this place, it's very difficult.
Yeah, now we see clearly. Yeah, now we see clearly that
this is a nodule
the stent is malformed.
The situation is similar here.
So diagonal is okay. No shifting.
This is the proximal part of the LAD. This is a position here also.
We don't have
we
great symmetry here, but it's difficult to require to have symmetric expansion in this very calcified vessel. Yeah.
That's right. So we can define malapposition when we have more than distal stent distal lumen is more than 20 micro-m, so it's we can define here like a malapposition. Similarly here in the proximal part of the LAD, I think it's a malapposition. We can
so I think what we need to do is to post dilate. I think at least we try to post dilate with 3.5 and see.
Yeah, that's right.
3.5. So
definitely in this longitudinal view, you can see the ostium of the intermediate artery. It looks.
So Sylwia, do we need to do something with the takeoff, because angiographically it doesn't look perfect? There is, but on OCT.
On OCT, the ostium it looks quite good. So, it's wide, so
just use struts across. That's use struts across. This is exactly the the takeoff of the branch, because we see the second wire appearing at 5 o'clock. 2 wires actually. So so from the one.
But looks at the. I think it can be. Because I'm not sure, it's circumflex rather here on longitudinal view, because it's
Sylwia, trochę głośniej jakbyś mówiła.
Okay. So there was ostium of intermediate artery, and now we can see the ostium of circumflex artery here. Yes, so. It looks.
And there is some plaque. The only thing is that there is some plaque protrusion here.
There you can see the ostium is plaque protrusion. Yes, that's right. So I will try to look at the longitudinal view. And the ostium is quite wide.
Yes.
However, there is a plaque protrusion because, as you remember, the plaque at the distal part of the left main was rather lipid rich.
Yes.
So the plaque was soft. So the risk of
we will try to
protrusion
correct it to a 3.5 balloon, because this is exactly at the ostium, and then we reconsider the DLAD.
There in the left main, in the proximal part of the stent, there is also some malposition of the stent here.
But these are 2 wires, under the struts.
There is significant dissection. There is dissection here also at the proximal part of the left main. So there we can see edge dissection.
Okay.
The rupture of the
But
calcified plaque.
is it what's the circumference of the dissection? Is it more than 60 degrees? What's the thickness? And is there any lumen compromise? Because we need to know whether we should intervene or not. Now we get the Acco force 3.5. We check, we don't need to be at the edge because there was no issue.
Tu się ten balon całkiem dobrze.
22. Nagrajmy. Ok, i Arek robimy boosta. Tak, możemy? Chwilę proszę teraz nie oddychać. No jest lepiej, aczkolwiek nie idealnie. Nie? Due to some plaque protrusion in the distal left main, we decided to post-dilate once again with 4.5 and the patient was given integralin. So good news is that the minimum stent area in the LAD in this underexpanded region is more than 8.5, which is really a good result. So I don't think we need any more post-dilatation. So we will never obtain the symmetric expansion of the stent. The only thing, we have some small edge dissection of the left main. So Sylwia, let's check once again with OCT, and we have to decide whether to cover this proximal edge dissection in the left main, or how big is dissection, what's the space between struts and the lumen. So let's go again to the proximal part of the left main.
Okay. So, after the bifurcation, we can see there is the expansion of the stent is quite good, but there you can see the protrusion of the plaque to the vessel lumen. And there you can see, unfortunately, you can see a thrombus inside the lumen of the left main. Yeah. It's a big thrombus, red thrombus here.
So it's really interesting, and again, fantastic images provided by the OFDI system. And we show definitely that there are first a dissection, some tissue prolapse, and some thrombus within the lumen. So, Thomas, any question from the chat?
We have for you, Maciej, very practical question, just asking, looking at the beautiful OFDI picture you have in the left main, how you will manage this in terms of drugs, but also of device, meaning additional PCI, additional stent or not?
Thank you, Thomas. So, having seen this not very beautiful image of a thrombus, we decided to two things. First, to give the patient integralin, so to block the platelets. And the second thing, to skip the right coronary artery at this moment, because we know that something is going on within the left main. And look, we didn't see it on angiography. So if we hadn't done the OFDI, we would proceed for right, and then we might be in a trouble, because something wrong could happen within the left main. And the third thing, we decided to cover the small, it was not very long dissection, but very deep. So we decided to add one more stent to cover the first one, and to heal this plaque protrusion, and also to capture some thrombi at this level. Actually, we might have expected this, because we saw in the first OFDI image that there is a lipid-rich plaque at the bifurcation of the left main, and this translated into the outcome after stenting.
Yeah, indeed, Maciej. I think it's a beautiful example to show that sometimes to assess the PCI result, you cannot just rely on the angio, because in this case, as you said, you can just finish the case and being in trouble a few hours later.
Yeah, exactly. You're right.
Okay, so now it will be interesting to see what you have done, and we move to the cath lab.
Yeah. And here it's bigger and bigger, and
okay. So I think we have to put another stent.
Yes, definitely. And at the end of at the proximal edge of the stent, you can see plaque rupture here. Plaque. This is as you can see, this is a calcified plaque with thin cap, and it's ruptured here.
Yeah. Okay. So we definitely we will cover, because also keep in mind that there were some soft tissue visible at the left main bifurcation, and so we need 40 of 3.5, because that's the same stent, 12 millimeter long. So we. Dobra, let go. So this is 4.5 post-dil of the stent, the second stent that covers the ostium. So finally we cover the ostium. Okay, go down. And we hope that now we remove by putting more struts across this soft protruding plaque, we stopped the thrombus formation in this patient. Yeah? So okay. So let's check angiographic result now, and of course we do final OCT. Okay. Yeah. So angiographically, the result is very nice. So now let's check with the OCT.
Jest 70. Okay.
Okay, so let's check the final OCT image. So we still see this calcified nodule, but as I mentioned, there is more than 8.5 millimeters square minimum lumen area within this region of the LAD, which is really very nice. So that's one point. We see a much better now coverage of the left main, with still some small thrombi close to the struts. Yeah, so this is it. So I think it will be resolved because now the flow, there is no dissection, the flow is STEMI free, and the patient is on integralin. So the whole thing is covered with the stent. Yeah, including the ostium. You see the apposition of the struts is very nice. Okay, let's go to the, and the stent covers the ostium of the left main. Yeah, so so the patient will stay on integralin infusion. If I can do the final injection without the wire, okay. So we have very nice STEMI free flow, and angiographically, and go to the caudal view, and angiographically the result is looks perfect. But now we know again how angiography can mislead us, and check in this caudal view. Looks nice. If you compare this image as for the ostium of the circ and the ostium, could you replay this as for the ostium of the circ and ostium of the intermediate branch? They look exactly the same. They look exactly the same. So there is no compromise, which has been just confirmed with the imaging. So Marek, what do you think? Is it? I know that it was also your decision, but what do you think about postponing this right coronary artery?
Yeah, I think that it's a very wise decision, because safety is first. The patient is so far stable. We have very good pressure, and as Maciej has mentioned, I think that it was an excellent demonstration how the imaging during the procedure completely changed the strategy, because without OCT we would never appreciate that something's wrong is going in the left main. So we should use imaging as only it's possible in majority of the cases, and in left main, of course, is a must.
Especially for this big vessel. So the patient, as Marek mentioned, is stable. There is no ECG change right now. The pressure is really good. Actually, it's even too high, because it's 180 now. So we can the patient is pain free, but so we don't need to give nitrates. But I think with this pressure, with this result, and antiplatelet medication, the platelet thrombi will resolve quickly, and the patient will leave home soon very safely, and then we will invite a patient for the inspection of the left main, and of course we'll fix the right coronary artery.
Yeah.
Oh, that's a great result. Great result, and geographically by OCT. We have some mainly three major questions for you, Maciej. The first one was, how was the immediate outcome of the patient in the first 24, 48 hours concerning any chest pain, ECG changes, or troponin elevation?
Yeah, thank you, Jean. The clinical course of this patient was completely uneventful. So nothing happened to this lady. There was a slight elevation of troponins 3 times the upper normal limit without any ECG changes. So we didn't diagnose the MI as a complication of PCI, just myocardial injury, because the troponin I went 3 times upper normal limit. And so the patient was released home, I think, the 3rd day after the procedure, and will come back next in 2 weeks' time for the right coronary artery.
Okay, and concerning the DAPT regimen, what was a special regimen for him, for this particular patient, compared to the standard left main PCI?
Yeah, this is what we do in a complex cases. We switch from clopidogrel, which is unpredictable drug, to ticagrelor. So she left on aspirin and ticagrelor, and until the right coronary artery PCI will stay on this kind of DAPT, and we will prolong until one year after the procedure. She was not a very high bleeding risk, so we can do this.
And Thomas, there was a question concerning also for the chat concerning the right.
You mentioned that already, Maciej. It was the main comment or question we had from you is about the timing of the right. You will stage, but you mentioned already that it will be in 2 or 3 weeks. But did you decide to delay a little bit the PCI of the right because the PCI of the left main was probably more complex than expected, or it's your usually timing to stage in patients with multivessel disease?
Yeah, every stage we give at least 2 weeks time to our patients. Now, due to COVID and the hospital overload, we prolong it to 1 month, roughly. Yeah.
Okay, thank you, Maciej.
Okay, thank you, Maciej, and it's time to recap, and what we have learned from this session is in the first part. It was a very nice talk from Thomas on the complete versus incomplete revascularization and the concept of functional complete the vascularization, which is in favor of better prognosis for the patient. The second was the fantastic case, and really we saw the importance of intracoronary imaging in this particular situation. We saw the high quality images provided by the OFDI system, and thanks to these high quality images, it was really important, and in this particular patient really these are the major impact on the strategy of revascularization with integralin and an additional stent implantation. So I would like to thank you, Maciej. Thank you for all your team in Poznan. Hope to see you very soon. Again, thank you for this really educational session. Of course, I would like to leave you by the big thank for Terumo company. With the support of this company, we'll add this really interesting educational program. Thank you again for Terumo.